a case investigator with the county, Jimmy Dogo, who is Director of Africa House at the Immigrant and Refugee Community Organization, Manu Malo Alailima, a member of the Pacific Islander Coalition, and Dr. Jennifer Vines, Multnomah County Health Officer. Our speakers will say a few words and then really turn it over to you for your questions. Kim Taves and Dr. Vines, just so you guys know, will also be available for you on Thursday at 1 to recap the weekly COVID briefing to the board. They'll also speak more on disease spread, the mask guidance, and offer some messaging heading into the July 4th weekend. And with that, Jimmy, my friend, do you mind muting yourself?
Oh, sorry.
No, you're good. With that, I think I will turn it over to Kim to get us started.
Hi, everyone. Good afternoon. My name is Kim Taves. I'm the Communicable Disease Director for Multnomah County Public Health. And we wanted to let everyone know some of the changes that we've seen in some of our cases and in terms of some of the specific communities that are having some increases in cases and some of our approaches and strategies that we and our community partners are using. I think everyone has been familiar across the United States with some of the differences in data that we've seen emerge over the last few months, with different folks being at different levels of risk for severe illness based on some of the racial inequities we have in chronic diseases, as well as some of just the risk of exposure from different communities having higher or lower chances of being in essential employer status, needing to interact more with the public, especially with people who are infected. That's not only healthcare, but that's also some other types of essential services, including food processing plants and others. And we have seen that happen in Oregon as well, and in Multnomah County specifically. I think from the early days of earlier spring, when we started to have the spread of COVID-19 locally, we've seen increased rates among Latinx communities, specifically folks who work in food processing industries. We had some concerns about migrant and seasonal farm workers who may become exposed either on site working together locally, or may have been exposed in a country of origin before they traveled to the United States to work, or from outside of this state to into Oregon to work. We in May became concerned, as well as the Pacific Islander community, identifying themselves, that we had some cases among a number of different Pacific Islander populations. And then most recently, we've had some concerns about some other immigrant populations, specifically some refugee populations and immigrant populations of African and South Asian populations. So we all wanted to be able to share that information with folks across all of our different populations. Some of the trends that we're seeing that put people at risk are the same trends we're seeing across all the different community members. I think people have been concerned that some of the increases are related to our moving as a Multnomah County into phase 1 reopening. And I would say that right now what we're seeing is that primarily it's not the specific sectors of businesses that have reopened, because we're only within about 2 weeks of that starting. It's more the general social sense among all of our communities that reopening means people are starting to re-engage with extended family and friends that they had not been in contact with the previous few months. That's happening nationally. That's happened as the other counties that are our neighbor counties reopened before we did. And that message follows through with Multnomah County. I think what we've probably had is we've had too fast and too much of an increase in people expanding their social connections with each other. And we needed to be a little bit more paced and more slow about that, to expand our circles slowly. And what we're seeing subsequently is some of that case increase that we did expect and we did thought. We just want to make sure that it happens at a rate that doesn't overwhelm our hospitals and that doesn't particularly burden any specific community with a higher rate than any other community. So we're here today to describe a little bit what we are doing with some of our immigrant specific communities, what our outreach strategies are, how we're partnering with community partners. And we definitely have methods and ways that we're getting the word out, not only through mainstream media, but on the ground and through community organizations and other pathways that we have. Wanted to let folks know so they can understand sort of what are the different components that we're all doing. Dr. Vines will talk at the end about how this messaging holds true with some of our prevention strategies across all of our different communities. And as we all head into July 4th, we have some concern that we may see some of the same levels of social interaction that we saw around Memorial Day weekend, which I think is in part what's causing some of our case increases. So with that, I think I'll turn it over to David Cuevas. And the idea that we're inviting David Cuevas is he's one of our case investigators, and you all have heard a lot about contact tracing specifically and how we've needed to not only have multilingual and multicultural staff at the community level with community-based organizations with whom we've subcontracted, have their capacity to work with community, but we also need to have that internally. And David has been a longstanding public health professional working with our team on a variety of different types of diseases, who's more recently focused on COVID-19 with us to share some of what is that experience from that perspective. And then we'll also hear from Jimmy from Africa House and IRCO about some of the ways that our community partners are working with community as well. So I think with that, I'll turn it over to you, David.
Thank you, Kim. Hello, everybody. My name is David Cuevas. I'm a disease intervention specialist, and I'm a contact investigator for the communicable disease services. Here at the Multnomah County, we always believe that culturally competent and compassionate contact tracers play a very important role in soothing the fears of a positive diagnosis on a client. The concept of cultural competency goes beyond race and ethnicity. It includes empathy and respect for all aspects that shape that patient's lived experience. And that can be from gender identity to sexual orientation, housing status, country of origin, and of course the language that they speak. This makes us create a better relationship that actually will make our interventions more effective. So what we do here at the Multnomah County, once we get a case reported to us, we do it through lab reports, electronic lab reports. We gather all the information necessary about that case. We have access to electronic medical records where we, what we call is the pre-interview analysis. We gather all the information about where would they tested, where they went with a family member, would they tested at the hospital, is a family member helping them translate or interpret during the visit. Do they go by themselves? Is somebody else from that same household went with them? We gather all this information, including the language that they speak, in order for us to reach out to them. What we do is we try to assign those cases, especially if somebody speaks the specific language, we assign it to individuals like either case investigators or contact tracers that speak the same language. If we don't have that, that capacity, what we do, we use an interpreter service. So we use an interpreter service, which reach out to them. Sometimes we can get a hold of them. We leave a voicemail in the language and in English, because sometimes we notice that somebody in the same household may speak English. And if we don't have that ability, we don't get a hold of them. We actually have text messages. We can send text messages in their own language. We have templates in different languages, and we send it to them, trying to reach out to them. Once the person reach out to us, we do the same contact investigation that we do to somebody that is an English speaker, meaning that we want to gather all the information. When did your symptoms started? Where were you 2 days before those symptoms started? Were you with family members? Did you hang out with somebody else? Were you working? Yeah. Where did you work? All that information we gather, which is our contact investigation. Once we gather that information that will help us stop the spread of the disease, what we do afterwards is do the education piece. We explain that to them, like what is quarantining means, what isolation means, what kind of things you can do around your house in order for you to spread the disease within your family members. How do you notify your employer? Situations like this. We understand that this is a lot of information, and sometimes even for an English speaker can be a lot of information to get in one phone call. So we offer them, we text them or mail them information in their own language. What we ask them is like, you know, I understand that this is a lot of information, so let me give you some more information like videos. We have the ability to text them links to videos in their own languages. We have the ability to mail information in their own languages. Once we do that information, most of the people, what they want to ask us is the same questions that we get a lot of the times. It's like, how do I notify my employer? How do I get my family members tested? where should I take them to get tested? And sometimes I ask you, like, one of my family members may not have insurance, where do I can get them insurance? All this information, along with our community partners that we have at the Multnomah County, we're able to direct them, to need. This is when all these partnerships that we have, we sometimes tell the individual, like, you have a little more concerns. What we're going to do, we're going to share your information with a local community partner, where they will be calling you to provide you with more services. And I'm going to leave Manu Malo so he can explain that how that process works. Thank you. Go ahead, Manu.
Hello, Falava, Malo Lede. Greetings in my native languages from Samoa and Tonga. I am an Malo Alailima, and I go by Malo for short, and I use all pronouns. I also greet you with Ali, Tiro, Hafade, Aloha, Rananim, Lakwe, and Kasalele. These are other Pacifica indigenous languages that are spoken here in Multnomah County from the islands of Palau, the Marshall Islands, Saipan, Wahan, Chuuk, Pohnpei, and Hawaii. I am part of the Pacific Islander Coalition, which is a culturally specific advisory board to Multnomah County Health Department. And we are a collective of Pacific Islander organizations like the Micronesian Islander Community, Living Islands, Regagal Balau, the Samoa Pacific Development Corporation, and the United Territories of Pacific Islanders Alliance Portland. So on the onset of COVID-19, we have been in contact with Multnomah County because we were blessed to have a culturally specific program senior specialist for the Pacific Islander community. And her name is Virginia Luca. And we were able to convene in order to address the impacts of COVID-19 for our particular community. So what that looked like for us was, how does communication look like within several subcultures within our community? So looking at language materials that are being translated. Another aspect is getting our other community members, such as our faith-based organizations, involved in helping us get the word out to folks in our community that may not have access to social media or the internet, so that we can reach out to our harder to reach members of our community. We've also teamed up with Multnomah County to actually have testing drives so that our community members could feel comfortable being tested with host organizations that they trusted and knew about. And we had two testing drives this past Saturday on the 27th, and our first drive was on the 20th. Our first drive, we were able to test 217 people. This past Saturday, it was 284. So it's been a huge ordeal. Like every week, looking at the Oregon Health Authority's weekly data report and seeing that the Pacific Islanders' rate of infection has been the highest for the past 9 weeks. And that's not something that we feel comfortable leading in. June 24th was the last data report, and it was 118 per 10,000. And it's a lot of work. It's a lot of work to try to reach out to as many as our folks that we can to ensure that they're tested, that they are isolating appropriately, quarantining if they have to as well. But we have such a drive within our community to do these things. In fact, it's to the point where we're helping other people in other counties, like in Marion County, Union County, as well as Washington County. So yes, it's great to partner with Multnomah County because it made a huge difference for us. One of our community-based organizations, Utopia PDX, will be hiring 2 Pacific Islander CHWs that can help do this work. And there's just other moments where there are certain gaps, and Multnomah County was able to help us through some of the unfamiliar territory to provide the services that we want to within our community. So at this time, I'll pass it over to Jimmy.
Can you hear me? Hello?
We can hear you, Jimmy.
All right. So again, thank you for this opportunity for our refugee community. Most of those refugees are coming here. Some of them are still new. Some of them are under 5 years or 10 years. And some of them are even less than a year. And they've been here. And especially refugees from Africa, like the Congolese, the Somali. We have also the Bhutanese and the Burmese. Those are the population the most affected. And then they're going through a lot of challenges when it's come to, you know, educating them about COVID-19. One of the challenges is that because the refugees live in a close quarter, you know, very dense, you know, population where multiple families live together. So when one person is infected, it's hard to do social distancing because some of the family members do not have any other place to go. So it spread quickly within their household because there is no way to do social distancing. And then also, most of those refugees are likely to have, you know, underlying health conditions like blood pressure, diabetes, and other chronic disease that they brought with them from a refugee camp. And so the COVID-19 is already, you know, hindering most refugee community ability to address this need within the refugee community. So it add more pressure on community-based organization like ours that are trying to figure out how to help those refugees. So one of the things that we said we can, you know, help those families with is to do testing. So so without additional resources like adequate testing capacity or expert assistance, or if we don't have those, it's going to be really hard for those communities to recover. It will be very, very slow to recover. So by partnering with Multnomah County, you know, we're planning to do testing in those different communities. Not only testing, they have to go to testing center, but we're planning to bring those tests to where refugees live. We bring those tests to them so that we encourage them to get tested. And to do so, we decide to do outreach to the community through businesses, to religious places, and then work also with our partner to make sure that we connect those who are infected to adequate resources so that they can, you know, protect themselves, as well as we educate them so that they don't have to, you know, spread the disease. And in doing so, because most of those refugees are illiterate, some of them are illiterate even in their own languages. You may give them material written in their own language, they may not be able to read. So what we are doing is do an audio translation on WhatsApp. And then because pretty much all refugees have WhatsApp, that's how they communicate with their family, either back home or in refugee camp. So our staff will translate those in a specific language and then disseminate those information to the refugee community so that they can get, any information in English that put out by Multnomah County Health Department or by CDC or any local, health authority. We take those material and then translate it and make it audio and then disseminate in the community. We also help those refugees to access certain items that will help them prevent the spread of COVID-19, such as personal protective equipment. So our staff will distribute this. They call the family, and then they go live at their door and make sure that they get out the apartment and they get those protective equipment. So those are the effort that we are doing in the community. And this morning, we have a meeting with Bhutanese community and religious leader on the challenge that they're facing, because this is one of our refugee group that is the most affected. So we find out that there is 16 family that include 95 people that are affected by the COVID pandemic. That does not include those who lost their job because of the pandemic. Those are the families that are infected by the disease. So those are the challenges that we going to the community, and this is the same with the Somali community and also the Congolese community. So doing this kind of outreach, partnering with Multnomah County Health Department will help a lot by providing adequate testing for our community so that we know who is infected and where they can go get help, and then how we can also trace, family who are infected and also their relative or friend who are visiting them. One of the challenges we are facing is refugees continue to do religious, worshiping in their apartment, or they have a refugee community gardening. So those are also places where this disease is spreading. So we want to educate them to make sure that they need to stop, doing those religious performance within their apartment or in their living room with so many people, in one place without social distancing or PPE equipment. So those are the things that we've been doing in the community. And I want to also take this opportunity to thank Multnomah County Health Department for coming to our help. Thank you.
Thank you all, and good afternoon. I'm Dr. Jennifer Vines. I'm the Multnomah County Health Officer. I want to thank everyone who's spoken so far, and I'll just offer some final brief sort of big picture comments, and then I think we'll take some questions. So I do want to thank our community partners so much. As we know, cases are increasing. We expected them to increase as we and our neighboring counties reopened. That said, we are very concerned about the pace of that increase. And as you've heard here, the public health response takes a lot of work. It takes a lot of committed partners, and it's really after the fact. So by definition, we're looking for people who have the virus. We're looking for people who may have been exposed to the virus. We're sort of like firefighters, and what we need from the public, especially going into the July 4th weekend, without a vaccine, without reliable treatment, with a virus that spreads very easily, we need the public's health around prevention. So as people think ahead to this holiday weekend, everybody, the safest thing you can do is stay home and stick to your household. And I should point out that this remains a Centers for Disease Control recommendation for people who are high risk. In general, outdoor gatherings are safer than indoor, and the fewer people, the better. For everybody, no matter how large your group size, if it's anyone outside your household, again, fewer people is better. But absolutely everyone should be wearing face coverings. So that goes for people hosting, it goes for your guests. And again, the fewer people, the better. So please expect to wear a face covering, expect anyone you interact with to wear a face covering. The governmental public health system is watching the numbers with some anxiety. And so everybody knows our toolkit for response here is pretty limited. So again, I'm calling on the public heading into the July 4th weekend to please take all the precautions that we've advised around physical distancing, face covering, and really limiting your interaction with people who you haven't seen in a while to the extent that you possibly can. I think with that, I'll turn it back to Kate Wilson, but I believe we have time for questions.
Yeah, I would invite reporters joining us through the Zoom app. You should have the power to unmute yourselves and ask questions. Please ignore the standard Zoom email that asks you to submit those to me. Please ignore that and feel free to unmute yourselves. If anybody's calling in by phone, if you dial *6, you should be able to mute and unmute yourselves. And with that, I'll just open it up.
Okay, this is Simon Gutierrez with KPTV. I have a question.
Go ahead.
This is for Dr. Vines. Early on in these ongoing protests, we heard from the county that you were looking into what was then described as fewer than 5 cases of COVID-19 possibly related to the protests. Can you provide some more details about those cases? And is the county seeing more of them in people who have attended protests since?
Yeah, I'll respond as best I can, and I'll invite Kim Taves to chime in as well. Our case investigators are asking about attendance at any kind of gathering, any kind of mass gathering, which would include protests. People can voluntarily disclose or not where they've been. I will say that our public health response is not always set up to figure out where people got infected. It's more to understand where they may have exposed other people and quickly get to those downstream effects, as opposed to looking upstream to where the source of their infection is. So I don't know that we have details on those less than 5 cases. That was a quick brush or a broad brush stroke with the best information we had at the time. That was early on. And I'll turn it over to Kim Taves to see if she can elaborate a little bit more with the understanding that this is something that we're trying to understand, but we may not have the most detailed information you all are looking for.
Thanks. This is Kim. I need to ask my team if the number is greater than 5. I know that the number is still very small because the team alerts us if they do start to see trends. We all, as a regional set of health officers in public health, did decide that if there were a number of cases from one specific night, one specific event, that we would go ahead and share that information out with the public. And that has not reached the threshold yet for us to do that. So we do feel like that is not becoming one of the areas of focus that seem to be part of the story of a significant driver of recent transmission.
This is Amelia with OPB. I'm interested in hearing from Manu Malo what you think it will take to bend the curve in your community and to no longer have such a disproportionate impact on the people that you work with.
Well, there's a combination of reasons. So like some that were shared earlier by Jimmy and David, there's a population within our own community that are living in multi-generational, multi-family homes. And if a number of those people are part of the essential workforce working at food processing plants and just being exposed to a higher risk of exposure, them coming home and having the ability to infect people within their household is one issue. Another is having proper translations in the correct manner of explaining the messaging around physical distancing, as well as using face coverings and washing of your hands. And then there's those folks that are harder to reach that don't have access to the internet, won't be able to see this broadcast, and trying to work with faith-based organizations to figure out a good plan on how to get this messaging across so that our folks can be tested and be properly identified for isolation and quarantine and given the proper wraparound services that they need. Another thing is trust. So yesterday I was on a call and people were reluctant to tell other people that were in their household or tell officials how many people lived in their household because they didn't want to get them in trouble, because they might have been over the limit of what was on the lease. And it's really scary, because when you think about public health, you know, is there a verification of certain things that may endanger the whole entire household? And so I think we need to do better in our messaging as far as how that looks like, if we really want for people to get the proper care and to slow the spread of this disease. We are working tirelessly for some solutions, but those are just some of the things. I'll give you an example of a family. So there is a uncle and 2 cousins that work at a food packaging plant, and the way the PPE is administered to them, some of them are drenched by the time they come to their 6th hour of working. I don't know if the employer enforces like changing out their PPE, because sometimes they'll take off their mask because they can't breathe at that point. So I think if there was a food processing liaison with the county to kind of help mitigate these things, explain to our workers that they have rights, if they're too tired to take on longer shifts, an additional shift, another day, that it's okay for them, you know, to rest, to get the proper rest. So I think as I'm hearing these different narratives from folks that are being impacted directly by COVID-19, they're all interrelated, they're all interconnected, and there's no one solution. There's many paths to that solution. I hope I was able to answer some of your questions.
Yeah, very much. Thank you.
Hi, this is Alex with the Portland Mercury. I know last week we heard that there were just high rates in general in the immigrant community. And I know that demographic data doesn't include nationality or immigrant status for good reason on the county site, but I want to understand if the immigrant and refugee community is disproportionately overrepresented in these positive COVID cases right now, or if it's, you know, just a concern that there's going to be a rise and trying to make sure to handle that right now. But does the data reflect that there is kind of a disproportionate number of folks in this community testing positive?
This is Kim from the Communicable Disease Services. Our epidemiology data shows that there's a significant disproportion of people of color in general across the board. We have some specific data about different ethnic groups, but we also have a lot of our qualitative understanding when we look at a broad racial group. Our qualitative understanding from working with the people who are infected and talking with them about their families and their households and their contacts is where we get a lot of that more rich data about exactly who is at highest risk right now and what some of the dynamics are. So if you look at our regional data dashboard, you'll definitely see across those broad racial categories, and those are our, you know, what we call our federal 5, that there are significant increases for a number of them. And within that, then, we do know qualitatively for sure that there's an overrepresentation of people who are in immigrant populations and who are specifically in refugee populations as well, which are smaller immigrant populations. And the reason I'll point those out is it tend to be smaller immigrant groups, and it tends to be groups that maybe have an ethnic origin in one country, but lived primarily in a refugee camp in a different country. Family members may have been born in the United States, but be of that ethnicity. And there may be multiple levels of barriers there for folks to access services and reach services, especially because of some really significant levels of trauma, both by our own government as well as by governments of countries where they have stayed or where they're from. And we're very much aware of what that level of trauma means in terms of how that plays out with accessing services and feeling comfortable and trusted, giving us information. I don't mean to say that that's only among immigrant populations, because we certainly have communities of color, the Black community, Native American communities that have had some significant histories of distrust for very good reason with our US government as well. And specifically with our public health system, if you look back over a number of decades of some of the practices that we've had. So that's in no means to say that that's unique to those folks, but we're just aware that there's the multiple layers there that are in addition to some of the language barriers, as well as some of the poverty that comes with being an immigrant, or especially being a member of a refugee community. And as Malo mentioned, with some very specific examples, some of the challenges folks have in some of the work sites, and how in some work sites, some folks are overrepresented. They may be work sites that are essential services where you don't need to have English reading and writing skills. And you tend to have work sites where you're paid lower income wages. There's a little bit more concern about your job security if you call in sick. Maybe your employer hasn't really clearly articulated to you that there is job security if you do need to leave for being sick, and you feel some pressure to show up even if you are sick and maybe not disclose your illness, as well as some of the concerns about the spacing of people at the job and the protective equipment. OSHA did make some changes this spring that I know that a lot of companies have been trying to be able to change their workflows to incorporate those changes to protect workers better. But that's not across the board at the highest level yet.
Hi, this is Selena Tibor from the Oregonian. Just wanted to say half a day to Malo. My family is from Guam. So it sounds like the county is really relying on community groups and community leaders in these immigrant and refugee communities to help reach those community members. So I wanted to ask these community leaders and these community groups if you feel like you have the resources to do all the outreach that you kind of have been asked to be doing all the translation services, reaching members of the community. Do you feel like you have what you need right now to do what you need to do?
Well, again, this is Jimmy Dogo from IRCO. So far, we don't have all the resources, especially when it's come to translation and interpretation. We have refugees speaking so many different languages. So, as I said earlier, our plan to do, to partner with Multnomah County to do community testing, we on finding, errors and translator as well as other volunteers. What we have in place right now, a few years ago, Multnomah County helped us to train community healthcare workers in the different refugee communities. So we have a community healthcare worker who are ready to assist, to help. And then those community healthcare workers, now we got support from the county to hire a few of them from most affected, refugee population, to provide education and support, as well as contact tracing. But we still have a challenge on translation and interpretation, where we want to continue asking for help so that we can recruit more interpreter in different languages from those different communities to provide support. We did get funding from Multnomah County to hire community healthcare worker to do the work. So the support is coming from Multnomah County, but it's, again, is not enough to do all the work. And we are just beginning with this kind of work. So I'm not gonna be shy to say that we need more help. Yeah. And then we also need COVID-19 resources that are culturally sensitive for our community, and also for where they work, the school, or even a home setting. So those materials should take into consideration also cultural sensitivity. This morning, I was talking to one community leader who is saying that, yes, the testing is okay, but what guarantee you're giving us that those tests are not going to spread disease in our community? So those are the things that we continue educating people that the test is necessary so that we know who is infected and how we can provide, guidance and resources. And even if we have to provide, resources, including medicine, healthcare, we connect them with healthcare provider, or even provide mental health services to them and their family.
And then I just have a quick follow-up question for the county. Do you feel confident in your relationship with community leaders and different community groups across immigrant and refugee communities in Multnomah County? Do you feel confident enough that you have all the people you need to do that outreach, or are you hoping to connect with more people and just do more outreach by working with community leaders?
This is Kim, and also let David and Dr. Vines add in if you want. I think that we have grown more different connections with community partners from communicable disease specifically in new and different ways in the last few months than we had before. I think that we've historically worked with smaller numbers of diseases and smaller numbers of folks. We've always had strong connections with immigrant community for some of our TB work. We had community partnerships growing when we had the concerns about Ebola, with measles in specific communities. But this is a whole new and different level. I think that we have had more strong partnerships with our community partners in our chronic disease realm than in our communicable disease realm. So while we've had connections, we're leaning in more to a deeper sense of connection, as well that the needs that all the communities are having right now are different. Jimmy mentioned that there's not only the people who have an infection right now in their household, but we're also seeing that all of our communities have had a huge impact for a number of different families based on the policies that the governor and that the county enacted this spring to try to reduce the spread. That's been a huge impact for people losing their jobs, which meant that they've lost some of their housing security. They've had food scarcity issues. That's impacted people whether or not they actually got infected with the illness. So our outreach and our strategies right now, whether it's from public health or it's from our community human services that works on food scarcity, emergency rental assistance, and housing stability, we're all trying to reach communities to help support the communities for that kind of stabilization, not just the disease transmission itself. So there's a lot of work. I think we're growing it, is what I'm saying. We've trained a lot more community health workers really rapidly. We've got a whole communications team that has been putting out information in multiple translations, but it's not enough, as Jimmy said. We just in the last few weeks have started to get executed contracts out to community-based organizations, and we are standing up testing now that's culturally specific. Part of also that we need to be aware of is the diversity in Multnomah County and in Portland is incredible. The language diversity we have and the diversity of religious practices and how people live and what their cultural preferences are. Some of the spread of infection is happening very rapidly, so that it's not stable. It's not the same specific communities right now that it was 3 weeks ago, or that it certainly was 3 months ago. So part of what we're needing to do is really make sure that we're able to very rapidly respond in a way that I think some of our other diseases are much more slow moving, and it gives us a little bit more of a chance to create a structure. Right now, the response has to be very, very fast. And so that has some of its own challenges. I don't know, Dr. Vines or David, if you add.
Yeah, thank you. I appreciate the question. I wanted to highlight one thing, and that is you've heard from Malo, you've heard from Jimmy, and from David. I think you've heard the role of trust and how big an investment we're making in these relationships, and how that develops over time. And so I just point that out to underscore it as questions inevitably come up around public health enforcement. Again, this is a big reason, and you're seeing it on display here today, for why voluntary efforts, trust building, giving communities what they need in the way that they need it, we find more often leads to success than a heavy-handed approach. So I really just wanted to emphasize that.
This is Galen Etlin at KGW. I've got a quick question about mask enforcement. We've heard a lot of people concerned, especially in those essential work sectors, more vulnerable people on the front lines, that companies, grocery stores are not really able or not always willing to enforce mask requirements. So at the county level, maybe these community group levels as to what kind of resources are there for companies, employees, customers to pursue concerns for noncompliance?
Sure. So there's OSHA, that's the Occupational Safety and Health, is one route for complaints around businesses. And I think Multnomah County is still in the process of doing a lot of outreach, again, with trying to make it easy to use a face covering, trying to provide just easy things for business owners and others to say. And then, as you've heard me point out today, to simply make it a social expectation that people, certainly when they're indoors, are simply expected to have their nose and mouth covered. And I don't know others if you want to chime in with more.
I might jump in here. We've got a question from Letitia Jensen with Willamette Week. Letitia, do you want to unmute yourself?
Yeah, hi. My question is for Kim or David. It is, what is something you wish you did or wish you had known earlier that you could have done to support the immigrant and refugee community in order to avoid such a disproportionate spread? Were you able to hear me?
Yes, I think. Yeah, I can answer to that. Well, when I echo what Kim was saying, the spread of the disease has been very, it just hit us really fast. So one event can actually change the way the curve goes. Like we see before, like happened in Union County, one single event in a church can actually drive all the numbers up. And the same with different communities, like one single event, one single, even like a family gathering can change those numbers and affect one specific group of people. And those communities, get affected. And I mean, we have a lot of partnerships with communities that before that we were actually dealing with a small amount of illnesses. And it was easy to reach out to them, but when you see a group of people being affected, I mean, it's because of the situation right now, even those partners are not working at the same level that they used to work before the pandemic. So it's hard for them even to reach out to their own community members. So, I mean, it's just a whole cascade of events. I mean, we wish we can have everything moving as fast as we can. We're trying to do our best, but yeah, that's a situation that happens just because everybody's standing still because of the recommendations that we are following. So it is difficult to reach out to those communities, but yeah, I mean, we're constantly working and improving that.
And this is Jennifer Vines again. I will just offer up my answer, and that is following H1N1, which was the closest thing resembling COVID-19 back in 2009. That was the new flu strain that circulated. One of the learnings from that was that these relationships are not easy to build in the middle of a public health emergency. And so Multnomah County at the time had plans to invest in an ongoing way in these communities' relationships. And unfortunately, some of that work ended up succumbing to shrinking budgets. So there are plenty of health issues that we could talk about in these communities beyond COVID-19, where we certainly have, we think, help to offer and learning to be gained through community leaders. So I think this is simply a renewed lesson about having these relationships in place, not only ahead of an emergency, but in an ongoing way, because again, health issues are not just limited to communicable disease.
Thank you all. I think unless we have any last burning desires from reporters.
I have one last question. It's Amelia with OPB. For people who are COVID positive, isolation and quarantine is sort of one of the critical recommendations. And I'm just wondering, how do you do that? How do you tell people to do that in a culturally sensitive way when you have these multi-generational families and maybe one person, you know, a young person who's helping translate for older people, and a lot of interdependence within these families?
This is Kim. I'll give some of our general recommendations for how we're working on that. And then if anyone else wants to speak about what that might look like in specific communities, please do. I'm well aware that a number of our folks who are infected with COVID-19 don't actually feel super sick. And if you're not feeling particularly sick, you can definitely feel in a household like you want to continue to contribute, to do your share of the cooking, to do your share of the childcare. It can be really boring and isolating to try to separate yourself from everyone else. Sometimes there's certainly space issues with doing that. There's also, I think, a tendency among many different cultures to take care of people in your family who are sick, shower them with good, healthy food, and entertain them if they're feeling miserable. And so that often can mean that people in the household, as well as people, you know, cousins and nieces and nephews, can stop by to see someone who's sick. And so it's a really hard time for any of us right now to try to ask people who are sick to isolate themselves alone. It may actually be easier if you don't feel very well to do that than if you're one of those people who have a mild illness. We're asking people to identify one person in their household who can be the primary person taking care of the sick person, and that they can wear a face covering and have the sick person wear a face covering when they interact. Be really careful about washing hands before and after, and just give that person a free pass, basically, from doing some of the daily work of running a house that usually households of families of people share together. We do have options for people if they are sick and there are a number of people in their household who are vulnerable to getting more severe illness and they're very worried about transmitting it. We do have options for people to stay at motel that we can help pay for, and we can help bring food to them while they're there if they want to stay there for 7 to 10 days while they're recovering. And we've also explored options, and we have connections that the communicable disease team that David works with know about, to reach out to someone in our emergency management team if it seems like some kind of sheltering situation like that for recovery and isolation is important outside of the house, but maybe that motel isn't the most appropriate setting. Then we have some other options we can help explore to try to problem solve in that way. And I don't know, Malo or David or Jimmy, if you have any other like culturally specific considerations beyond some of those general guidelines that I've given, you want to share?
Yeah, again, just like you said, one of the challenges that we see in those refugee community is that, when the entire family is infected, it's hard to practice, social distancing, especially when, household member become sick, test positive, and then the person that is not positive trying to take care of everybody else without having, temporary housing that will help them practice social distancing. So that's why we have the challenge right now that those who try to care for the family member infected end up being infected themselves because of the practice of social distancing and hygiene and all those. So those are the challenge we're facing. And we also have some family members still see this as a stigma. Some community members feel this as a stigma. They're not sharing this information to the rest of the community. So therefore, there are some people that may end up, visiting, saying that because people is still, when somebody is sick, they want to make sure that they go visit and all those. So this is another challenge that we have. But for those who are well informed, they get all the information, so they tell people, please don't visit us. We are in quarantine. We are going through a lot of challenge now. Wait, don't visit us. So those people, especially the young people, who are tested positive, they still have energy to continue providing assistance to the rest of the family. But the only challenge is they have to leave their job and then care for the family. And then when they leave their job, they apply for unemployment. Some of them are waiting for the last 2 months to get unemployment. So it put more burden on the family as well on the person that is caring for the rest of the family. And that's where we really need help with temporary housing and also other assistance like a gift card to help those people who are still waiting for their unemployment benefit to kick in so that they can continue providing the support that the family needs.
Thank you to everybody. Thank you for the panelists who came, and thank you to reporters for joining us. And just a reminder for reporters that you will have Dr. Vines and Kim Taves again on Thursday at 1 o'clock. I'll send out a notice tomorrow on that. Again, thank you all so much, and stay well.